Thank you, Jorge, for the introduction, and thank you for inviting me today to present, and a big welcome to everyone out there in the audience. I'm on Worimi country, and I acknowledge the traditional owners of this really beautiful land, and I also pay my respects to all First Nations people who may be in the audience today. My presentation is going to discuss the impact of COVID-19 and the triggers that we've identified that may exacerbate mental health issues for people from refugee background living in Australia. I will also talk about the Watch cohort study, which I lead, and data showing stark and confronting differences between the mental health of refugee women during the COVID-19 pandemic and a comparison group of Australian-born women. My presentation will also demonstrate that the pandemic and during the pandemic, it's vital for practitioners such as yourselves to be well supported and resourced to respond to these unique issues that are affecting the mental health of people who arrived here as refugees. And I really want to stress that we need to ensure that people from refugee background do not suffer greater and disproportionate morbidity and mortality during and related to COVID-19, as we've seen play out actually in the USA and the UK. So of the 26 million people who are from refugee background, approximately 1 in 10 reside in high-income countries, and of course, many of those living in Australia. They've commonly experienced trauma related to violence and insecurity, persecution, and shortage of food and medicine. Our research from the Watch study and the scoping work to inform the main COVID-19 analysis suggested that COVID-19 and its health and social sequelae may be triggering past traumatic reactions, exacerbating mental health problems, and undermining functioning. When I refer to a trauma trigger, of course, I'm talking about a psychological response to a situation that may recall or induce recall of a traumatic experience, as well as increased anxiety and distress. So the first trauma trigger, so these are the qualitative descriptive insights that we got during the scoping phase. They're really important. The first trauma trigger I want to talk about today is fear of illness and death. Widespread disease and death related to the virus can cause significant anxiety and fear for our own health and for our family members, especially those, of course, who are older or are children or have existing illnesses. We know from the statistics that COVID-19 presents a serious health risk and an increased risk of death for us and our family members. So, not surprisingly, the fear of death has recently been shown to predict not only anxiety related to COVID-19, but also play a causal role in various mental health conditions. People from refugee backgrounds experience compounding anxieties that concern family members who remain living in conflict-affected or low-resource countries where the virus is spreading and where health care is poor or non-existent. So I've heard harrowing stories of this, including from my own staff, who come from low and medium income countries where their parents and other family members have been sick with COVID-19 and they've been unable to be there to support them.
Susan, sorry to interrupt you. Are you sharing any slides?
Oh, you can't see the slides?
No, you can't.
Oh, okay. Sorry about that. Okay. So that's my my first slide. And
yes, you can see them now. Thank you.
Okay, sorry about that, everyone. And that's my acknowledgement to the traditional owners, which I have done. And now I'm just talking about, yes, that we really need to make sure that we're not, going to contribute to or see the same kind of disproportionate morbidity and mortality that we've seen in relation to COVID-19 in other countries. And then I'm talking about the research that we're doing, and this is the study that we published on our, from our insights into the formation of the forming of the study, the scoping work, and then the fear and death of illness I was on to. So just to give you a quick summary through the slides. So then I was talking about family members and how, we don't want to, and I've heard these harrowing, stories from my own staff who come from the same countries and they've not been able to, share them with and they've not been able to, be there to support their family members, which is a really important issue for so many refugee people living in Australia. It's a separation from family. So the risk, of course, is heightened further if the home countries has added threats to the safety for people and for family members, such as the situation we're hearing about right now in Sudan, where Sudanese Australians are currently very fearful for the safety of their loved ones with all the violence and chaos related to the military coup in their home country. So these additional compounding factors add to the distress. There's no doubt that being unable to return to the country of origin in an emergency to support or protect those family members can contribute significantly to mental distress. And also, by the way, for some, a kind of a manifestation of a survivor guilt. So COVID-19 has led to increased government controls, including restrictions on community freedoms and activities. People who arrived as refugees have often escaped repressive regimes, and some have associated these intensified use of government powers here with the harm and loss of life that they witnessed in those countries. Police and military presence to enforce restrictions, including lockdowns, can be experienced as a threat rather than as a protective mechanism. That's what's happening. And fear and distrust of authorities is triggering anxiety and rumination and anger, and post-traumatic stress symptoms can worsen as refugees re-experience these past acts of military repression. A government and army presence was inequitably applied recently in Sydney across our local government areas, with the tightest restrictions being where there were the largest refugee populations. And you can see in my slides, there's a contrast between the people in the eastern suburbs of Sydney who are lying around on the beach having a great time, while people in Western Sydney were locked in their homes with army walking the streets and police. So this geographic distinction generated intense feelings of distrust and questions, actually, many of them questioning the fairness and equality that they'd previously expected from a democratic country like Australia. And the lack of value for the decisions made by authorities, and I mean, emanating from these kinds of policies, also, of course, has this flow-on effect where it reduces the willingness to engage with public health strategies, such as COVID-19 testing programs and with consenting to be vaccinated. So you would have all experienced some level of social isolation lately, especially people joining us in Sydney and Melbourne. Refugees are often socially isolated because of poor English language skills, low income, and of course having family members overseas, as I said. Social support and connectedness with family and community are among the strongest predictors of recovery following any trauma. And mental health professionals therefore routinely encourage people from refugee backgrounds to build their social networks and to connect with the broader society. However, in the COVID-19 world, communities had to socially isolate and to restrict social interactions, often for long periods of time, at the time when they most need to socially integrate. So we've had, documented experience, many kind of feelings and expressions around this, but feeling bored and lonely have been identified as particularly problematic, along with not being able to celebrate meaningful occasions with family and community, including religious events, of course, birthdays and funerals. While social isolation and distancing are part of our collective effort to contain the virus, and we know that, and they're important, professionals do need to understand how and why this may be exacerbating mental health problems and how it can also undermine progress during settlement. Lockdown and quarantine, as I said, have been part of our life for the past year, And these will probably be used again in the future to control the rate of transmission and hospitalizations. And the experience of lockdown and quarantine have caused anger and confusion and distress in general populations. We've seen people out demonstrating and feeling and expressing their anger. But for many refugees, lockdown stress can be more traumatic because it's exacerbated by past experiences of forced detainment and imprisonment. We've documented during COVID-19 traumatic memories of restricted freedoms of movement and the feelings of injustice associated with it, and often the associated acts of physical and psychological violence as well perpetrated against them during detention, such as torture. So this presents, of course, a significant risk for exacerbated mental health issues during COVID-19 in this population. Regardless of the actual level of food shortage during the pandemic, people from refugee backgrounds expressed adverse psychological responses to media reporting and their direct experience as well of panic buying. I'm sure you all remember images of people queuing in the supermarkets here and fighting over toilet paper. Some refugees associate economic hardship, especially risk of food and medicine shortage, with a threat to life. Threat to life, of course, being, a central feature in post-traumatic stress disorder. Further to this, food shortages had often occurred at a time, in its most severe form at times of war and conflict. Those things are conflated. And so this situation is triggering intrusive memories of conflict and threat from the past. Recent reports predicting economic hardship and lower standard of living all contribute to these states of anxiety. We're hearing about this a lot now in the media. And so, of course, we're also facing government cuts, financial payments to people during COVID-19, and this is a huge source of stress for many people. So further to poor communication related to COVID-19 policies, or on this topic, this undermines really the capacity to discern which information is correct and which is fake news. Nothing's clear and no one can determine what they're hearing, out of all that they're hearing, what's right and what's not. This means that people from refugee background with a lower level of competency in English have often been more vulnerable to this anti-vaxxer and misinformation, and less likely to trust messaging from health authorities, including on COVID-19 vaccination. It has had a big impact. Many refugees come from countries where they just can't trust state-run institutions. And there are many examples from refugee-producing countries where persecuted minority groups have received poor quality healthcare because of their minority status, or they've heard about or experienced, their family members have experienced lethal treatment in hospitals. It's therefore not surprising that fear strikes and avoidance sets in when people from refugee background need to go to hospital or to consult a health professional. Trust can be undermined further when the patient is not familiar with the dominant language, of course, or culture or mode of consultation. And especially actually this culturally foreign telehealth services. A combination of not having trust in health services and hearing about and seeing on TV sick people being forcibly isolated from their family members in hospital has led people in Sydney recently to die at home with COVID-19. This is an avoidable tragedy that just can't continue. During the COVID-19 outbreak, refugees really need to know who to trust in order to support worrisome symptoms, as well as to understand and have confidence in medical advice and the hospital system, and this needs to be a priority area of focus. I've talked about the triggers that indicate the need for specialised psychosocial responses for people from refugee background during COVID-19. But what about the empirical evidence linking COVID-19 with mental disorders? The most referenced or research reference point available to us regarding the impact of COVID-19 related stressors on mental health actually derives from the general population in high-income countries. These studies have shown associations between psychiatric symptoms in general and more specifically depression and anxiety related to the COVID-19 pandemic. A UK study found that socially disadvantaged populations, for example, those with lower incomes, experienced more adverse mental health impact from exposure to the pandemic, and that understanding unique social and cultural histories and personal experiences of COVID-19 were really important in determining the relative psychiatric risk. An Australian study led by Dr. Belinda Liddell at UNSW used a convenient sample of people from refugee background and reported that worries about being infected by COVID-19 or worry about the risk of COVID-19 to others predicted health anxiety and PTSD. They also reported that social-related difficulties predicted depression and disability. And they found that the strongest predictor of all mental health outcomes was COVID-19 reminders of difficult past events, which is completely consistent with what I've just discussed with you and shared with you with respect to our descriptive reports of the trauma triggers. Women from refugee backgrounds, which is my area of interest, living in Western countries may be experiencing heightened stress during the COVID-19 pandemic because of pre-existing vulnerabilities arising from exposure to gendered traumatic events, and these include things like rape, sexual assault, intimate partner violence, their higher baseline level of common mental disorders and unique psychosocial challenges that they confront during the resettlement process. The WATCH study is all of 1,335 women aged over 18 years of age, systematically recruited at antenatal clinics in 3 Australian hospitals servicing large refugee populations. It's approximately half refugee background women and half Australian-born women. And the main outcome variables that measures that we use include the International Neuropsychiatric Interview, the MINI, the World Mental Health Survey Trauma Events measure, the World Health Organization measure for intimate partner violence, a post-migration living difficulty checklist, the ASQSE, which is measuring development in kids, and COVID-19 questions, a whole host of them, and an exercise measure as well, which is added. So this is a quick look at the waves and the excellent retention rate that we've been able to maintain. And you can see below at the very last section there is the subsample of women who participated at time 4 after COVID-19 hit Australia, and they've been given the specific COVID-19 questions, so as anchors to the other changes that we can see across time. We would not have this track record without our impressive and amazing UNSW research assistants and cultural advisors to the WATCH cohort study. They're all named there, and I just want to thank them all so much for the work that they do for us and for the study and for women. Most of the refugee women participants in our study were born in Iraq, followed by Lebanon, Sri Lanka, and Sudan. This paper from the WATCH study highlights why this is a really important area of study in the field of trauma and the mental health of women settling in high-income countries. It underscores why this is a particularly at-risk group as well during highly stressful periods, particularly COVID-19. From the baseline cohort, we reported that the prevalence of perinatal depression for refugee women was significantly higher than Australian-born women, 25.1% versus 14.5%. And it's important to know that the prevalence for depression was much higher in both groups if there was intimate partner violence. And as I mentioned, although a higher prevalence of psychological disorders has been associated with the COVID-19 pandemic in general populations, none have actually examined people from refugee backgrounds in large studies that include probability sampling and mental health diagnostic measures. I considered that prior traumatic events, higher prevalence of mental disorders and contemporary social adversity may confer a unique risk for mental health problems during COVID-19. So we drew on the Watch study to examine and compare the prevalence and type of mental disorder in a sample of 650 women. And these were half refugee background, half Australian born during COVID-19. And this is a subsample of all those that were interviewed, so that the actual sample is much larger. This is a subsample who were interviewed during time 4, but after COVID-19 hit Australia, and they were given specific questions related to COVID-19. And we then examined whether the disorders were associated with the predominant domains of COVID-19 related psychosocial problems. Those that were extrinsic in nature, things related to material hardship, and those intrinsic in nature, psychological stress and fear. And we also measured intimate partner violence, of course, because of its previous association with mental disorders and its prevalence. The findings are striking and concerning, and we haven't published them yet. We're just preparing this paper. It's hot off the, we're doing an insight that no one else has had. Compared with the Australian-born women, we found that women from refugee background during COVID-19 had a higher prevalence of depression, 19.8 versus 17.5. More PTSD, 9.7% versus 5.1. Higher levels of adult separation anxiety disorder, and think back to the triggers that I was talking about in the separation from family. You can just see how grief and separation anxiety disorder would be high as it is, 19.8 versus 13.5, and grief 6.5 to 2.9, because of course refugees have more loss of grief related to COVID-19 because their families are not safely in Australia and much higher risk places for death. Refugee background women also had a higher prevalence of intimate partner violence, which we have published. Compared with Australian-born women, mental disorders in the women from refugee background were more strongly associated with COVID-19 related psychological stress or fear, whereas there was an association between most of the measured mental disorders and material hardship during COVID-19 found in both groups. Our study demonstrates that during COVID-19, women from refugee background are at greater mental health risk across a whole range of disorders. They're more likely to have experienced intimate partner violence, although it's high in both groups. And they're more likely to associate mental health problems and intimate partner violence with fear and stress related to COVID-19. So we've heard politicians in the media comment that with COVID-19, we're all in this together. Whilst this makes us feel a sense of unity and increases our awareness of the importance of supporting each other, it also assumes a level playing field. Research from the UK and the US shows that socially marginalised or disadvantaged groups like migrants and ethnic minorities, people with low income, will experience more psychiatric morbidity related to the pandemic than socially advantaged groups. Our study now confirms that this is the case for people from refugee background as well, and in fact far in excess of what I've seen in terms of, although no one's measured those disorders specifically, but even if you take a combined look at mental disorders, we're seeing very high rates, very concerning. So the origins of these disparities, though, are structural in nature. Historically produced arrangements of power and privilege provide socially advantaged groups with more resources to limit their exposure to and to cope with stressors caused by the pandemic. And for refugee background Australians, consider the issues such as the triggers I mentioned, as well as pre-existing health vulnerabilities, overcrowded housing, poorer ventilation, high-rise apartment living, poorer access to specialised healthcare, not being able to lie around on Bondi Beach, less knowledge and trust in advice, that's undermined, as I talked about before, the sense of feeling confident in what they're hearing from health authorities is severely undermined, and lower levels of understanding, therefore, why specific information is important. So I just wanted to finish then with one of my first points, and that is to stress that empirical evidence is needed to inform policy. And we need to be putting a big emphasis on this now. Fortunately, we have a cohort study and we're doing this, but we need to see more research in this field across the world, not just in Australia. And our practice must be fully supported. Your practice as practitioners must be fully supported to ensure that people from refugee background do not suffer greater and disproportionate morbidity and mortality related to COVID-19. Thank you very much.